Sagar Bhargav, sir. We all know him. He does not need an introduction. He's a senior clinician and surgeon par excellence. He's attached with BBI Foundation VIP and Netralayam, Kolkata. Previously, he was attached as Deputy Director Shankar Netralayam, Kolkata, where he served as Senior Consultant Glaucoma, Cataract and Refractive Surgeon. So look at the case. The patient is planned for right eye phaco with PCIL under topical anesthesia. A 60-year-old male with right eye in his grade 2. Normal fundus, normal IOP. This is the photograph of the slit lamp photograph. Fundus examination was normal OCT. Here's the specular count. And RL power calculated by Alma.
We are already with Sagar, and Sagar is one of our best surgeons in this part of the country. Sagar, thank you so much.
Thank you, sir.
Yes.
You are putting pressure on me now.
Centration, Sagar. So Sagar uses a small cotton swab to stabilize the globe. So some of us use the forceps, but this is a choice that the surgeon can do.
Would you like to speak something about the overlay that we are seeing, sir?
Yeah. So this is something very nice, and I think it entry exactly at 180 degree. Can we have the Rexus overlay? 5.25. Yeah. Right, so we'll go ahead with the Rexus now. So for Rexus, I like to stabilize the globe with the side port. I think it's not going in. Need to enlarge the side port. Side port enlargement. Round spatula है? नीचे देखिए, नीचे देखिए.
So little louder, please.
Right, so we'll stabilize the globe now. Light में देखते रहिए. हाँ, देखिए.
This is louder, huh? Melissa, you don't need mic. Chancellor main টা এখন বাকি স্তরের এখন সব শুরু হবে স্তরের এখন অডিশন বাকি আছে
Approximately 5.25 millimeter Rexus. Now go ahead with the hydrodissection. Yeah. Okay. Overlay निकाल दो. Low.
So Love is here with me in the OT. So I'm going to ask Love one question. Love, the Rexus that Sagar did the Varion follow the Rexus or did Sagar follow the Rexus marker?
Sagar doesn't need Varion or Callisto for Rexus.
So I'm going to do a horizontal chop. Am I audible?
Yes, yes.
Now this is a little softish kind of a cataract. So really I don't need too much of vacuum to do the chop. This is the beauty of this chop. Just little bit of clearing of the visco. So here it's a panel vacuum, and I really don't go in the nucleus. I just stabilize it, and then with the horizontal movement I just divide it. So without using much of vacuum, we have two pieces made already. So this is a soft cataract. It's always good to just stabilize the nucleus and achieve the crack. So you can see two nice cracks there. These are at times difficult in soft cataracts. And then with the help of your chopper, you can just lift the thing. Quadrant, please.
Sagar, what parameters do you prefer?
So this is about 350 to 400 vacuum. And I believe this is a White Star continuous Phaco. It's a variable White Star, if I'm not wrong. Yeah, it's about 45 power. And the beauty of this system is that the anterior chamber remains rock solid. There is no fluctuation in the anterior chamber, as you can see. And I need to see the fallibility is little less, so I need to increase the aspiration flow rate. So can we increase the aspiration flow rate to 40? So now the moment we have increased it, now see the fallibility. So this is the advantage of this machine. On table you do the adjustment. Now we'll tackle this piece. So gently we are creating one more piece out of that. So at no point my nucleus, my Phaco tip goes beyond the center. It's always at the center. Even if it is gone in the periphery, bring it to the center and then aspirate it. That ensures that you are away from the endothelium when your ultrasound is on. So the cataract was a little softish kind of a cataract. It's all gone now. We go to epinucleus settings now. So the parameters obviously now come down. Spatula. So that's it. Now we'll just remove the cortex and place the lens. So at all points the anterior chamber remains well formed if your wound is good, and you allow the pieces to come to you. It's a good habit to keep the anterior chamber formed when you're coming out at every point.
Yeah, that's a very important point, even though it is not a PPC, I mean, for every time, because the excursion of the PC as well as the vitreous body that it does during this acute phase is important to take care of.
Very high risk chance of PVD induction.
Yeah.
So nothing great in eye, basically you tease it off, bring it in the center and aspirate. This one.
So the lens that you've chosen, Sagar, is a Synergy lens, I believe.
Yes, yes.
Okay.
So this is a continuous range of vision lens, and it's a newer generation.
Yeah, it gives that benefit of the EDOF as well as the multifocal, and that's a great benefit for this. And I think most of us have used this lens, and we are pretty satisfied with this lens.
I think the near vision is the main advantage with this lens.
Yeah.
Excellent near vision you get.
Exactly.
And at all illuminations, all low light illumination, everything. So now we see some fibers in the PC, so we'll just remove them. A cap back.
So that's an excellent cap back, quite diligently being done.
So sometimes it doesn't come off, so you can use the cortex mode with visco in the other hand.
Yeah.
So with the visco injection, you can do that very comfortably.
Yes, I think that is a tip from the master. So let us repeat what Sagar said. So visco in one hand and the cap back mode in the other hand, or you can go into the IA mode also.
Visco. So we are ready now for the lens implantation.
So Sagar, every time he takes out the irrigation, he has the visco in. So in such cases, would you do a wound-assisted implantation, Sagar?
I've never been a fan of wound-assisted implantation.
Right.
I always like to go inside. Don't want to take a chance because with the wound-assisted, you end up distorting the wound actually.
That is true, because basically the nozzle is pushing on the wound, and the architecture of the wound definitely gets distorted.
Anyway, we know that anything below 2.5 is astigmatically neutral.
Yes.
So
yes.
why to struggle?
Why to struggle?
So the lens goes in the partly in the anterior chamber, partly in the bag, and then one can go from behind the lens and remove the viscoelastic. So rotation also is easy with this.
Yeah.
So we have been joined by Dr. Ashok Grover, Dr. Namrata Sharma, Dr. Rajesh, and also our own Dr. Saurabh Sinha in the panel room.
So thanks a lot, and that's a great moment in our lives. Dr. Ashok Grover sir, Namrata, and Rajesh joining us and coming all the way from Delhi. Warm welcome to all of you. Thank you very much. So Sagar, if
almost through.
Yes.
I'm just basically trying to center the centermost ring to the corneal reflex.
Thank you, Partho. Great to be here and privileged to be here. Lovely setup. We've been enjoying your hospitality.
Thank you, sir. Thank you very much.
Fantastic, Partho. This thing looks beautiful, Netralayam, with Monideepa, of course. Wonderfully done. You are very lucky, Partho, to have Monideepa.
Thank you, Namrata.
Partho, truly you are very lucky, and it's a wonderful hospital. Very nice. Congratulations.
Thank you so much. It's been a big teamwork for all of us, and the whole team deserves a lot of appreciation for the hard work that's been done. I have done the least.
I know, that's why I'm saying you've not done anything.
So I'm done. So as the patient is looking in the light, you can see that the reflex is in the
Yes, can you center it
area.
a little more, Sagar, so that we can
Partho,
see
you
that.
don't have to feel guilty about not having done anything. I didn't do anything from my center either. I just did the planning part of it. So sitting down with the architect and so on to plan. The rest was done by her.
Means you just said yes to everything. You had no option.
So I think it's a very well-centered lens, and the reflex is looking absolutely perfect on the lens. So thanks a lot, Sagar. So let's give a big clap, and that's a master at work. Thank you, Sagar. Thank you so much.
Thank you for the opportunity.